Hi, class. Welcome. It's Dr. Lindner. We are pretty much close to the end of um, the spinal cord and the plexi uh, lecture. We're going to finish up with some of this more clinical information. And I think it's important to understand now that we've covered some of these nerves, how can we assess some of these? What are some of the outward signs or symptoms that people can exhibit, and how can we assess some of these, right? So you're going to hear these terms, dermatomes and myotomes. So when we look at dermatomes, this is like a neurological mapping. Whoops, sorry, I don't know why my pen is messing up. Let me erase that. A neurological mapping of the skin are dermatomes, and myotomes is a neurological mapping to myo, which is muscle. So we are going to try and understand, are there certain patterns to nerves from the neck and nerves of the lower back that control sensation to the skin in different parts of the body? That's dermatomes. And myotomes, are there certain patterns to nerve roots that control muscle groups? Okay, so every spinal nerve is going to have both sensory and motor nerve fibers. The dermatomes, those are sensory, and myotomes are going to be motor. So the dermatome is an area of the skin supplied by a spinal nerve. And when people experience weird sensations, they typically refer to that as like a paresthesia, an abnormal sensation. There is a unique dermatome to the face, and it's not controlled by a spinal nerve, but it's actually controlled by a cranial nerve number 5, which is called the trigeminal nerve. It's trigeminal because you can see that this cranial nerve has 3 divisions. It has a V1, it has a V2, and it has a V3. V refers to cranial nerve 5, which is trigeminal. It has 3 divisions, right? It's called trigeminal, meaning 3. V1, V2, V3. So when you go to the dentist, this is the cranial nerve that they inject with Novocaine so that half your face goes numb. And they want to be able to hit V2 if they're working on the upper jaw, or V3 if they're working on the mandible. But usually they hit pretty close to that ganglion right there. And then what happens is half your face goes numb, including your tongue, right? So the trigeminal nerve has a dermatome that goes to the face. V1 is known as the ophthalmic branch because it goes to the eye. V2 is the maxillary branch going to the upper jaw. And V3 is the mandibular division going to the lower jaw. When we look at dermatomes, we can see that the cervical spine, the thoracic spine, the lumbar spine, and the sacral spine, right? C is for cervical, T is for thoracic, and then the L's are for lumbars, and then you'll see occasionally the S for sacral. So each region, if we want to look at C5, C5 is the arm and the outside of the shoulder. C6 is the lateral forearm to the first 2 digits. C7 is the birdie, it's the middle digit. And then remember thoracic outlet syndrome, which was the C8 and T1 nerve root of the brachial plexus that was being compressed by either pec minor or the scalenes. And the symptoms were the medial forearm, pinky, and half of the ring finger, because look where the T1 and the C8 dermatomes are. So if you have a nerve impingement in your neck and we think C5 is involved, there's going to be lack of sensation or some sort of paresthesia, too little or too much sensation here. If we think the problem is at C6, then there's going to be too little or too much sensation to this lateral part of the forearm, first and second digit. If we think C7 is involved, then the middle finger is too little or too much sensation. Now, how do we know if it's too much or too little? Well, that's where they take a Wartenberg pinwheel and they may say, okay, can you feel this, the thumb part of C6? And they'll say, does it feel like this? They'll go to the other thumb and we do a bilateral comparison. Does this feel like this? And if you say no, then we would say, okay, does this feel more or less than this? And maybe they'll say it feels less. And then we'll say, okay, we think this is less. How does this feel to this? It feels the same. Well, then maybe this whole thing is less. Well, let's compare this one to this one, to C7. So I'll say, okay, how does the thumb feel to the middle digit? And they'll say, oh, this feels less than this. Okay, how does the middle digit, how does this feel to the pinky? Well, they feel the same. All right, how about the mid forearm? How does this feel to this? So it feels the same. So everything else feels the same, but the only place that there was involvement may have been the C6, and there was less sensation. That was the conclusion that we came up with in that particular instance. Notice that the thoracics, T4 is a nipple line. Around T10 is the belly button. Those are some landmarks. And notice trigeminal nerve goes to the front of the face. But you know where there is no dermatome? C1. C1 does not have a dermatome. It looks like it starts at C2, C3, C4. And you'll be like, these numbers don't make any sense. Like, what's the order to this? And you're right, from this position, it doesn't make sense. But in quadruped, if you're on all fours, then it makes sense, right? You could see C2, C3, C4, C5, C6, C7, C8, T1, 2, 3, 4, right? Then it makes sense in this position. Now, what I drew on this, what I drew on here for you was showing not only the dermatomes, okay? I want to go back here for a second just to look at the lower extremity. You could see in the lower back, you got L1 over here and L2 over here, L3 over here, L4 going down the inside to the floor, and L5 to the top of the toes, and S1 to the pinky toe, and S1 to the bottom of the foot. This helps us understand, like if someone slipped and fell and they hurt their lower back and they said, oh, I'm numb on the inside of my great toe and the inside of my shin, I'm thinking it's L4. If they go, oh, I can't feel the bottom of my foot, then I'm thinking, well, maybe it's here, maybe it's S1, right? So you have to think multi-dimensional, right? You have to think, okay, this could be a dermatomal issue. Let me know what these dermatomes are. So now from here, besides the dermatome, what I put over here are the myotome. The myotome. So these are the muscles and the actions that these nerve roots control. So C5 controls arm abduction. When you abduct the arm, that's the deltoid. So if they can't do that, well, there could be a problem with C5. C5 also controls elbow flexion, which is the biceps brachii. C6 nerve root controls the wrist extensors. C7 nerve root controls wrist. You should have wrote this out. Wrist flexion at the wrist. It does wrist flexion. And at the elbow and the fingers, if you have trouble pushing a door open because you can't extend your elbow or you can't extend your fingers, these three actions are controlled by C7. So I like to do, wrist flexion, finger extension, and elbow extension. I kind of make like a number 7, right? When you flex the wrist and your fingers are extended and your elbow is flexed, that's a number 7, but then you extend it. So it's elbow extension, finger extension, and wrist flexion, all controlled by C7. C8 controls finger flexion. So if someone's telling you that they have a weak grip, or you shake their hand and you say squeeze it tight, and they can't do that because the fingers are weak, or they hold a glass and it slips out of their hands, they don't have a strong grip, maybe the problem's at the C8 myotome, the C8 nerve root. And then T1 does finger adduction and abduction. Finger adduction and abduction. So these are myotomes. So, and off to the right, over here, we have reflexes. So if the person had arm abduction that was weak and elbow flexion that was weak, and I'm thinking, I think that C5 myotome is damaged, right? That nerve root is weak, and they have numbness over here to the outside of the shoulder, which is C5. So now I'm saying, well, the C5 dermatome is shot, the C5 myotome is shot. Let me check the C5 reflex. Let me take my reflex hammer and tap over the biceps tendon and see if that's diminished. If they had weakness to the lateral forearm and the thumb and the index finger, this is all C6. If that sensation was diminished and they had trouble extending their wrist, I would say, well, the C6 dermatome is shot, the C6 myotome is shot. Let me check the C6 reflex, which is tapping over the brachioradialis tendon, and see if the elbow flexes. If their wrist flexion is weak, or finger extension and elbow extension is weak, and their middle finger has less sensation, I would say the C7 nerve root is damaged, affecting the dermatome, the myotome. Let me check the reflex. I'll tap over the triceps tendon and see if I can get the elbow to extend. And I might as well just put it down here in the lower back. There's an L4 reflex, which goes to the patella reflex. And there's an S1 reflex that checks the Achilles tendon. So now if we go down here to the lower back, we see L1, L2, and L3. That goes to the front of the thigh, right? L3 goes to the inner knee. L4 goes down to the floor. L5 goes to the top of the toes, top of the foot and top of the toes. And then S1 is the mirror image to what L4 is, right? So L4 is the inner leg. S1 is the outer leg. Now, if they said, oh, I'm numb on the inside of my leg, the medial side of my leg. So I'm thinking L4 could be that L4 nerve root is being affected as the dermatome. I'd say, okay, what's the myotome? So myotomes are over here. Myo is muscle. So myotomes, the L4 is your dorsiflexor, which is tibialis anterior. So if they have trouble walking, like stepping on their heel, their calcaneus, and they can't dorsiflex their foot, I would say, all right, now the L4 Myotome isn't good. The L4 dermatome is no good. Let's check the L4 reflex. Let me take the reflex hammer and tap over the patella tendon. If they said, I slipped, my friend played a prank on me, pulled out my chair as I was about to sit, and my butt hit the concrete. I heard a little pop in my lower back, and ever since I'm numb on my pinky toe, I'm numb underneath my foot. I'd be thinking it's an S1 issue. So S1 dermatome, S1 nerve root, S1 on the myotome, S1 is plantar flexion. S1 is plantar flexion, which is reach for the sun, because you're stepping on your tippy toes. S1 is plantar flexion, reaching for the sun, and hip extension. S1, plantar flexion, and hip extension. S1. So if those are weak, I'm thinking, okay, S1 myotome is shot. The sensory, the dermatome is shot. Is there a reflex for S1? Yes, there is, and it's the Achilles tendon reflex. Tap over the Achilles tendon, and the foot should plantar flex. Now, L5 does have a dermatome. It's the front of the shin and top of the foot and the top of the toes. And the myotome for L5 is toe extension and hip abduction for the glutes, like glute medius, hip abduction. So if you can't abduct your thigh or your hip, that's an L5 problem. And if you can't extend your toes, that's an L5 problem. So this is where muscle testing comes into play. You would simply test these actions on the individual. Now, L5 doesn't have a reflex, just L4 and S1 have reflexes. So these are called neurological packages. So depending on the severity of the damage, whether it's a cervical injury or a lumbar injury, we would want to test three things if possible: the dermatome, the myotome, and the reflexes. If there are areas that don't have three, like L5 does have a dermatome, and that is a myotome. It just doesn't have a reflex. In terms of severity, how bad is the nerve damage? Dermatomes are the least concerning. If someone has numbness and tingling to the fingers or to the feet, it indicates that there's definitely a nerve problem, but it's not life-threatening and it's not super severe. It is manageable. If the reflex, if they have numbness and tingling and it's ignored, if they don't see a doctor of chiropractic to address that injury from a structural and functional perspective, then it progresses and can lead to muscle weakness. Now, muscles being weak, they can still be fixed. But if it's for an extended period of time where muscle groups atrophy, that's a more complicated situation. Okay. And if there's no reflex, we've got some severe issues going on. So dermatomes, least concerning, but you have a dermatome that's ignored and then it leads to muscle weakness, still fixable conservatively. If it's dermatome, muscle weakness that's ignored, now it leads to atrophy, then it's much more of a complicated issue, and usually the reflexes will also be affected with that. Sometimes people will get, now, for cervical, brachial, lumbar, and sacral plexus, we spoke about all of those issues. We spoke about the plexus and we spoke about clinical things, but sometimes thoracic nerves can be impacted, especially the intercostals. And when you start to get this type of dermatomal distribution, when you get this virus that's called shingles or herpes zoster, where you get this blistering that follows dermatomes or that follows intercostal nerves. That's what shingles and herpes zoster is. Okay, so shingles over here, that's an infection of the peripheral nerve by the chickenpox virus, and it causes pain. It causes skin discoloration, and people feel often bruised, like they'll feel like deep pain or like nerve pain, and they can't quite explain it. But it starts off like that. It can linger for a week or two. And then if you look closely, you could see like a small blister. And then it becomes like a line of blisters. That's shingles. Polio, you've heard of polio or poliomyelitis. This is a viral infection that causes motor neuron death. But where the virus is, if this is the cross section of the spinal cord, right, the virus affects the anterior horn. When the virus affects the anterior horn, everything that comes out from the anterior horn goes to muscle. It's motor, right? The ventral roots, the ventral horns, that's all motor. So it's motor neuron death, and just doesn't cause death to skeletal muscles, but it can cause death if it affects the heart and the diaphragm, because then you get cardiac failure and respiratory distress and arrest. Neuritis is just inflammation of the nerve, and that could be caused from direct injury to the nerve. It could be caused by a vitamin deficiency, not just a deficiency, but even a toxicity. People who take too much B6 can end up with symptoms like carpal tunnel syndrome. Right? So I've had patients that think if they take something that's natural, they think it's safe. And for the most part, it's true, but too much of something or too little of something can certainly create problems. B vitamins, if you take too much B6, can create the same symptom of too little B6, which is a radiculopathy and then like a carpal tunnel. And neuritis can also be caused by certain types of poisons, chemical stressors. I did mention sciatica in a previous short video. It's irritation to the sciatic nerve that can be caused by a misaligned vertebrae. Arthritis, like degeneration of the bones, where we get bone spurs that are called osteophytes. Disc herniations or disc bulges, because discs can put pressure on nerves. And if there's an issue at L4 or L5 nerve roots, that can cause sciatica. Tilting of the pelvis. Tilting of the pelvis due to the orientation of the greater and lesser sciatic notches change. The piriformis muscle could be hypertonic or in spasm. You can have a scoliosis. You can have a decreased lumbar curve, which is a military spine, or a hypolordosis or a hyperlordosis, and even pes planus, which is flat feet. They can work up the chain of command from the feet, works up to the knee, works up to the hip, works up to the lumbar spine. It's that biokinetic chain. Flat feet, a lot of people may not understand why that can cause it. If you don't get the corrective, customized, specific orthotics, when the talus and navicular of the foot drop, you get tibial rotation. The tibia immediately rotates, so does the femur. And when that rotates, you can get stress on that piriformis. And if, let's say, the right foot is flatter than the left, the pelvis drops on that flatter side, causing pelvic tilting, changing the orientation of the greater and lesser sciatic notch. When the sacrum and pelvis tilts, the lumbar alignment changes, which can cause misalignments and disc herniations. So the feet can affect the spine directly.